brain fog, and we're here with Dr. Roger McIntyre. The format of today will be a discussion interview with myself and Dr. McIntyre, and leading into a Q&A at the end where participants will be able to ask any questions and have them answered by Dr. McIntyre. So as I said, we are here with Dr. Roger McIntyre. Nice to have you with us, Dr. Roger McIntyre. It's a professor of psychiatry and pharmacology at the University of Toronto. He is also the head of the Mood Disorders Pharmacology Unit at the University Health Network, and also the executive director of the Brain and Cognition Discovery Foundation, which is here in Toronto, registered non-for-profit organization with a focus on research and education in areas of brain health and disease. Now, Dr. McIntyre was named by Clarivate Analytics and Thomson Reuters in 2014, 2015, 2016, and 2017 as one of the world's most influential minds. This distinction is given by publishing the largest number of articles that rank among the most frequently cited by researchers globally in 21 broad fields of science and social science during the previous decade. So we're very happy to have you here with us, Dr. McIntyre.
Susie, yeah, it's great to be with you, Susie. It's absolutely great to be with you, and such an important topic. But just wanted to chime in and say, very nice to be with you.
Thanks so much. And we're really glad that you're having a study on long COVID, and let's get right into this. And what is long COVID, and what do we currently know about long COVID in terms of the brain?
Well, you know, it's a great question. It's a great starting point, and I'm going to put up on here a landing slide. Hopefully you can see it. Let me know if you can see it. You can see it okay?
Yep.
Okay, great stuff. Well, this is in fact, this has really become a international conversation, really, in terms of the discussion around this issue and what this condition is. Maybe we can just step back a couple of steps. First of all, is that we have had our lives affected by this global pandemic. This is the COVID-19 public health crisis that has affected every country around the world, regardless of its economic status. In other words, it's across the high, the middle, and the low-income countries. And so we have a global public health crisis. At the same time, we also have a global mental health crisis, and we've seen a rise in not just depression and anxiety, but many other types of mental disorders. And what we've learned in the last 2 years, and it's incredible, Susie, it's incredible. We're saying 2 years. I mean, 2 years now this has been going on. Yeah. We've learned so much now about the virus itself, the body's reaction to the virus. And we've also, in fact, learned a whole lot about what are the consequences in someone who's been infected by the virus but has recovered from the acute infection itself, the acute COVID-19 infection. And unfortunately, Susie, what's happened is that the infection rate has, as you know, has been extraordinarily high. Nobody really knows how many people are actually infected. We have approximately 300 million confirmed cases, approximately. And everybody agrees that there's no way that's the exact number. Everyone agrees the number is much higher, and it's anyone's guess. Some people think it's anywhere from 3 to 4 times that much, maybe even 5 to 6 times that much. I don't think we know, but I think most people would agree that it's a large percentage. And what we've discovered, Susie, is that there are some people who are acutely infected by COVID-19 and they recover and then otherwise back to normal, and just like, you know, a flu or a bad cold, they just have their life gets back to normal. And that's obviously very fortunate for them. Other people, about a third of people, Susie, they go on to have a medical problem, a mental illness or a neurologic problem like depression, or some people go on to have very unusual neurologic problems and so on. And this has also been described. And then there's how you pose the question, and that is the long COVID syndrome. And I think, first of all, we don't really have yet agreement on what the name of this is. There's been quite a few names that have been put forward, like long COVID or long haulers, post-COVID. And more recently, the World Health Organization has tried to put a name on this, so at least we have a common language around the world called post-COVID conditions. And really what it is, it's a group of symptoms that are occurring frequently in people who have been infected with COVID-19. They don't have depression or bipolar disorder. They don't have an outright anxiety disorder, but there's something going on. And people are really complaining about a lot of types of symptoms that are debilitating. And these symptoms are many. In fact, Susie, there's over 200 symptoms now described, attributed to the so-called post-COVID condition. Big number. But if I was to put it into groups, one group of symptoms are physical symptoms. People have unusual kind of heartbeats, and their heart rate is kind of a little off, palpitations. Some people have changes in their breathing parameters. So some physical symptoms. Other people have what we call cognitive symptoms, which just means like the thinking symptoms. So people have, what we call brain fog. Their mind's very foggy and very kind of dull. Like I always say, it's like the Pentium chip in your brain is kind of really slowed right down. And then other people have a lot of mood symptoms. They're kind of not feeling themselves. They're kind of not feeling much interested, not feeling much desire to do things. And a lot of people, Susie, you should know, have terrible fatigue. Like they're just so tired all the time. Fatigue in a way they just can't describe it. And I'm only scratching the surface. This isn't all the symptoms. These are some of the more common symptoms. And so then we do some blood tests. We do an X-ray. We do an MRI scan. Doesn't seem to be anything we can see. But whatever it is, it's common. In fact, about 10 to 30% of people who have been infected by COVID have these symptoms, and they're very debilitating. And it puts me in mind, Susie, of previous situations we've had. I remember in the past when we had SARS, we saw something like this for a little bit. And I also know from my own experience as a clinician, meeting many people who have conditions like Lyme's disease, or develop sort of chronic fatigue or fibromyalgia syndromes after they got an infection of some type. And these are just some examples. So medicine has become very familiar over, frankly, centuries of people at a very large percentage having a lot of these types of debilitating symptoms that first declare themselves after an infection, and this is no exception to that. I think what I'm most concerned about, Susie, is the percentage of people, very high percentage, and how long this goes on for, months and months and months, even after the acute infection has resolved, and people just can't function. So it's a very common, very persistent, and very debilitating condition, which we're calling post-COVID conditions.
That's right. And what are some of the proposed causes of long COVID brain fog? Do we know that yet?
I don't think we are really fully informed as to what the causes are. We do have some leads, and there are some important leads that maybe I'll speak to. Nobody is unaware that this virus, this COVID-19 infection, unleashes an immune response like not many infections do. And you've been hearing about this, the massive immune response. I mean, this is a very complicated virus, and our body is reacting to it with an extraordinary immune response. And I suppose that's a good thing, because we want to kill the virus or neutralize the virus. But the problem is you get what's called friendly fire. In other words, the immune system, in its noble effort to try to neutralize or destroy the virus, unfortunately, there is in fact this effect where the immune system could actually do some injury to your own healthy body. In other words, we know, for example, when the brain is exposed to an activated immune system for quite some time, what happens is the brain starts to function differently. Now, everybody has had the common cold, or just about everybody's had the common cold, and everybody knows what that feels like. In other words, you lose your energy, your appetite, you're kind of sleepy, you're kind of, not in a very good mood. Life is not that enjoyable. That's the immune system doing that to you. But that lasts maybe a day or two, a couple of days, you're back to your usual self. And there's many examples of this where we can, in a laboratory, we can recreate this experience by just provoking your immune system. And so there is, in fact, good reason to believe that the immune system itself, in its noble effort to neutralize and destroy the virus, there's some collateral damage, some friendly fire, where you start to see this effect on the brain and more specific areas of the brain that are responsible for how you and I think. Susie, our brain is comprised of different regions that are responsible for different functions. Some parts are responsible for sleep and appetite. Other areas of the brain are responsible for our mood and how we feel. Other parts are for motivation, and then other parts are for how we think and how we organize our thoughts. And depending on which area of the brain you look at, when you have this activated immune system triggered by COVID-19, you begin to see changes in those brain areas that are responsible for how you and I think, how you and I are motivated, the energy you and I have just to get up and do things for the day. And so people are complaining they have no motivation, no energy, no interest, their brain is foggy, and they can't organize thoughts. And those symptoms map onto those changes in the brain that I'm just describing. So we think that the immune system could be doing this. Now, not the only factor, but that's only one factor that's at play. For other people, there could be some other aspects involved. We're still trying to suss that out. But I think for now, what I would say is, and I use this metaphor, the suspect at the suspect line at the police station. For me, that suspect is most likely right now, right in the middle of that lineup is the immune system. So it then stands to reason, if that's the case, then maybe we can begin to think about how we might treat this. And there are a number of ways in medicine where we can give you a treatment that can affect your immune system in a positive way. But what we're also trying to do is not only affect your immune system. What we want to do is we want to affect your immune system in such a way that it directly helps those aspects of thinking and cognition and motivation and energy. So it's tricky. So in short, we think it's the immune system. If it is, maybe we can, through medicine or through some other intervention, boost your immune system better so you don't have these symptoms.
So in particular, the treatments for long COVID then would be boosting the immune system, or can you speak more of the treatments that are available?
Yeah, absolutely. So right now, we don't yet have a proven treatment for long COVID. There are dozens and dozens of investigators around the world that are looking at different treatment modalities. Now, there's a couple of ways in medicine that we try to approach this. Let me just describe the strategy first. One strategy, just imagine you had a rash. You had a rash on your skin. Well, one way we can approach it is top down. The other way is bottom up. So let me give you an example. You have a rash on your skin. We don't know what's causing it, but I want to give you something just to get rid of the rash, okay? That's a top-down approach. I don't know what caused your rash, but I got rid of it by giving you this ointment or this cream or whatever. Another way to treat a rash is bottom up. Now that we figured out what caused the rash, let's say it's because you are allergic to an antibiotic, penicillin. Well, let's get the penicillin out of your body. And by getting the underlying cause out of the way, the rash goes away. So one way is bottom up. We figured out what the mechanism is. And once we target that mechanism, the rash goes away. The other way is we don't know what the mechanism is, but until we do, let's just get rid of that rash. That's top down. So strategically, people are doing it both ways. Some people, what they're doing is they're saying, we don't really know what the cause of long COVID is, but what we do know is that people have a problem with thinking. Like they just can't focus. Their brain is fogged. And we have strategies that can help people focus their thinking. And there's a type of treatment called cognitive remediation. In other words, cognitive exercises to increase the musculature of your cognition. So people's brain is foggy, they can't focus, they can't think. So what you do is you do a bunch of cognitive tests and cognitive exercises to really get that muscle back so you can fight that fatigue and start to function cognitively normal again. Now, that's not looking at the mechanism, it's just trying to treat the problem. The other way, and what other investigators are doing in some parts of the world, is saying, we think the immune system is really a problem here. So let's give people immune drugs that can maybe just recalibrate the immune system, a bit like Goldilocks' porridge, not too hot, not too cold. So the immune system might be a little bit too hot thanks to COVID. So maybe we just kind of cool it a little bit, just modulate a little bit. And when you do that, then the hope is you're targeting the mechanism, and then ultimately people will be able to think and feel and be able to behave the way that they're most familiar with. That's another way of doing it. What we're doing, and I'm putting the poster up right now in our study, this is the first study like this in Canada, where we're taking both a bottom-up and a top-down approach. So we thought, look, we don't really know what's causing COVID, but we have good reason to believe it's an immune problem. We also don't know the full extent of the type of symptoms people have, but we do know most people have problems with how they think. Their energy is just about zapped. We know they're not very motivated. They feel very lethargic. We know that too. So is there a treatment we could give people that could be both top down, treat the cognitive problems, treat the fatigue problems, treat the motivation problems, at the same time, bottom up? Can we treat the underlying mechanisms? Do we have a drug that can affect inflammation? And we do. So we're doing a study with a treatment, and it's what's called a controlled study. So people who come into the study at our center, and on this poster you can see herein on the slide, what we have is the contact information. If you have long COVID, you think you might be interested, this is a safe and well-tolerated treatment. It's already approved in North America, USA, and Canada to treat a variety of conditions. And what we're doing is the following, is what's really interesting. How people receive this treatment, if they're eligible, they'll be randomized to the treatment or a placebo. And this treatment's targeting the underlying immune system, and it's been shown to improve your cognition, your motivation, your energy. And our thesis has been throughout this journey, trying to help people with long COVID, is that we have the capability of targeting the symptoms and the underlying cause with some very new medicines that we have at our disposal. So we're just starting it. If people are experiencing long COVID, first of all, it's an awful situation. We've met lots of people who are experiencing it. We know how difficult this is. Don't hesitate. Reach out to the number that's here. Talk to my colleagues. They'll speak to you. They'll answer all your questions. And if you're eligible, you may be able to come into this clinical trial targeting not just the cause of COVID, or at least one of the causes at least, and some of the most common manifestations of COVID.
And sorry, what was the drug, the name of the drug that you'd be using?
Yeah, this drug's called 40-oxetine, and it's a drug that is shown to be an antidepressant, but it's also shown to be helpful for anxiety. It's helpful for cognitive problems, and it has effects on the immune system. And to be clear, we use a lot of medicines we call off-label. In other words, we will take aspirin. Everyone knows aspirin. Well, we use aspirin if you have a fever. We use aspirin if you have pain, to reduce the pain. We use aspirin to thin your blood. Let's say that you've got a problem with your blood clotting. We give you aspirin so you don't get a clot. So we use drugs and medicine for different reasons, and aspirin is one of many examples. 40-oxetine was first launched as an antidepressant, but we use it for different purposes. And because it's a drug that can help cognition, help your energy, your motivation, your reward, and also recalibrate your immune system, we thought this would be an ideal treatment to really develop in the treatment of COVID, long COVID. But it doesn't mean the person has to have, in quotes, depression, if you know what I mean.
Okay, and how safe is 40-oxetine, and are there possible side effects?
Yeah, so very safe and well tolerated. It's approved in over 80 countries around the world. It's approved in Canada, United States. It's been with us for the better part of a decade. Its safety is well established by the government. The side effects it's actually quite well tolerated. Some people may have a little what we call GI or gastrointestinal upset, one of the more common symptoms, maybe a couple percentage points. And that's a really good point you brought up, Susie, because look, long COVID is really a burden to people's quality of life, and nobody wants to take medicine that makes them feel more crummy or makes them feel lousy. So the thought process wasn't simply about, oh, can we come up with a treatment that can affect the cause, like immunity, as well as the types of symptoms like cognition, but it has to be a treatment that's agreeable. It can't cause, a long list of terrible side effects. People feel pretty lousy. So this is a medicine that is one of the best tolerated medications we have in the area of psychiatry, and it's that was a very important part of our consideration in choosing this one for our study.
Okay, that's fantastic. So as far as cognitive impairment, how will this be assessed in your study?
Yeah, absolutely, Susie. So just so everyone's clear, so we're all on the same page, when I say cognition, I'm just referring to thinking. So we, as human beings, we think, we feel, we behave. And thinking can be sort of broken into different categories. In other words, I got to pay attention. That's an aspect of my thinking. I've got to be able to have a good memory. I got to remember what I did last week, where did I leave my car keys, remember phone numbers. That's my memory. So you got your attention, you have your memory. I also need to be able to process information efficiently, what I call my sort of Pentium chip in my brain. So I got to be able to process information. That's my processor, just like the chip on your computer. And then we have this other part of your brain, we call it executive functions. But what it really is the ability to kind of organize. So for you and I, Susie, to, let's say, organize a trip to the grocery store, meet some friends for a coffee, do some accounting, pay my bills, that requires a lot of organization. So the brain, when we think about cognition or the thinking apparatus of the brain, it's about your memory, it's about paying attention, it's your processing speed, it's also your organizational capacity. So what we do when we're measuring your cognition, and people who are eligible for the study, we're going to measure this for you. You're going to have this comprehensively assessed, as well as other aspects. We're going to check your immune system. And the cognition test that we have is evaluating each of those aspects that I just described: the memory, the attention, your ability to process information efficiently, and your organizational capacity. We have a variety of scientific tests that we can measure, and everyone's going to be tested on this before they start the study and at the end of the study, with the hope that our intervention will not only improve how you're performing, but subjectively, how do you feel? Do you feel your mind is sharper? Do you feel your mind's more crisp, more efficient? Do you find you're more organized? And we have those tests as well. So we'll be looking at different aspects of your cognition, and it's going to be evaluated with some of the gold standard scientific metrics we have in this area.
Great. This is really exciting. A lot of us have been waiting for almost some people over 2 years. So it's really great that this is coming to fruition. So thank you so much. Where will the study be taking place?
Yeah, great question. So the study itself will be physically located here in Toronto, and I guess Toronto is a big place. So for those who are familiar with the Toronto area, it's going to be in the Mississauga. We have a medical clinic there. But we're also aware of the fact, Susie, look, people are busy. It's not always easy to get to A to B, especially in Southern Ontario with all the traffic. And quite frankly, everyone now is familiar with, and I think much more comfortable with, using telehealth and telemedicine. 5 to 10 years ago, when I used to talk about telehealth and telemedicine, people are like, what's that? I think everybody knows what it is now. And I think a lot of people prefer it, actually, for a whole host of reasons. And so why I'm bringing that up is, although the study itself is physically located in Mississauga, for those familiar, just off Mavis Road, we have our center. A big part of the study, quite frankly, Susie, is, in quotes, virtualized. And we've done that because we appreciate people have lives and they have things they got to do and want to be as efficient as possible. And we're able to do most of the study, frankly, virtually. And so people who are interested, we're looking at people right across Canada, frankly, who want it. So this is not confined to people who live in the greater Toronto area. anyone across the country who's interested would be eligible to be part of our study. There's ways that the staff can flexibly arrange the measures, arrange some of the testing and so on. Again, a lot of this now is all done virtually. So physically located in Toronto, but that doesn't mean that you need to, slug your way over to our clinic, on a regular basis. There are some visits, but most of the things we're going to be doing in the studies can be virtualized. So it gives tremendous flexibility to people.
And it's a pretty quick study, is it not, in comparison with other studies?
Yes, it is. And I'm so glad you brought that up, because I have been involved in studies in my career over the last, 20, 25 years, where some of our studies are like, years long. This is not what this is. This study is actually just 8 weeks long. It's a very short study, relatively speaking. I mean, there's a bit on the front end, a bit on the back end, but really the study is very brief. So studies I usually do are quite long. This is a very short study, relatively speaking. And I think that's important because, look, we're testing this treatment because we have a reason to believe it can really help people. We don't know that, but we're hoping it can. That's why we're doing this. We want to help people who are suffering and who are from this terrible situation. And we've got reasons to believe this could be a successful approach. The other part is that, I don't want a treatment that's going to take 6 months to a year to work. We want treatments that are going to work within a couple of weeks. And based on the science of the drug that we're testing, we have a reason to believe if it's going to work, it's going to work very quickly. And that matters, because obviously people don't want to be suffering for more than they need to. We don't want this going on for months. So it's a short study. Much of the study activities for people who are eligible can be virtualized, so it's very user-friendly. Just contact information on the slide. Our team will be able to describe in more details how that will all kind of play out.
Okay, so we have some questions here.
Yeah.
Hang on a second, I'm just trying to get them up. Leanna, I don't see the questions here.
Hi, Roger and Susie. So if you open up the chat box, you'll be able to see some questions from our participants.
Okay, well, there's quite a few questions here. Okay, Dr. McIntyre. How do you spell the drug? Okay, we can go over that afterwards. Yeah, that's good.
Yeah, the drug, maybe we can even circulate some information. It's vortioxetine, VORTIO, vortioxetine, TIO, XETINE, vortioxetine.
And participants are available in Canada. What about North America, including the US?
Great question. For now, participants are going to be in Canada for now, and that's how we're starting this study. We will re-evaluate that over the next 2 to 3 months, but for now, it's confined to Canada. Absolutely. Okay. And unfortunately, as you know, Susie, we have a lot of Canadians who are affected.
Yeah. All right. Okay. So Holly's asking about the distance. She's a long drive from Ottawa. So your study can be done virtually, correct?
Yeah, many, if not most of the visits can be done virtually. And there's ways wherein through telehealth, we can actually make just about the entire study happen through telehealth. And there's ways that we can facilitate getting some of the tests done. Ottawa is not going to be a problem. Anywhere across the country is not going to be a problem, because we're going to really take advantage of the convenience and the capabilities of the telehealth, as well as the fact that, labs are close by. Of course, the labs that they use in Halifax or Vancouver, Edmonton, Toronto, we can access different opportunities and capabilities. So no, you would not necessarily you don't need to come to Toronto necessarily.
Okay, now there's someone asking about your age inclusion. Why under 65? So can you tell us why people over 65 would be excluded from the study?
Yeah, and that's a really, really good point. For now, and I'm going to emphasize, for now, it's 18 to 65. That might change later. So if you're over 65, or somebody's over 65 who may be interested or may be eligible and would like to find out more, please stay tuned. Feel free to contact our team. The contact information is there. If you're interested, you can leave your information with our team through the contact information if you're over 65. I can't guarantee anything right now, but we are in negotiation to, in fact, make it have to have no ceiling to the age. Whenever we do these types of studies, we have to select an age range, and we decide to go with 18 to 65 for now. But we've heard from a lot of people who are over 65 who want to be in the study. And there's a small tweak to the dosing of the medication we have to do in people over 65. It's not a big deal, but something we just have to, it's a bit of a process for us. It's not a major process, it's just a time process. And we are currently started that process to try and remove the upper age limit. So we have no upper age. We're trying to get it removed, so there's no upper age limit. So if you are over 65, you know somebody's over 65, you think might be interested or eligible, still call us. No guarantees. But if we have your name and you're interested, potentially eligible, if, and I hope when, but if we can get this upper age limit removed and then get the medication dosing for people over 65, we'll reach out to you and gauge your interest at that time.
Great. Now someone's asking about positive COVID test. In reference to the positive COVID test, I don't have one, just assume based on long COVID symptoms. By doctor's note, what do you mean?
Yeah, great point. So if you have had COVID, and most people have had a test, but I know many people have not had a test, and they have all the symptoms. They had someone in the house with COVID who was lab tested positive. So in other words, a spade's a spade, and it looks as though their doctor believes, they believe they got COVID. Give us a call, because our preference is to have the test positive. But we appreciate that many people haven't had the test. Some have lost their test results, can't get them, recopied, things like that. Don't hesitate, call us. You could still be very much eligible for our study. So our preference is to have the test, but we're being quite flexible around this. If there is in fact proof, if this is through your doctor's medical record, then that would be something we can discuss further with you.
Okay, there's just a couple more questions. As far as being on current medications, would this make you ineligible for the study?
No, not at all. So we appreciate people have lives to live. People have other reasons they take medication. They're taking medications for, this and that. Some people are taking medications for sleep or for anxiety or their mood. No, it is not. That doesn't make a person ineligible at all. Now, there is some fine print to that. Depends. There's a couple of little tweaks to medications we might do. But it depends what those are. And those are little details that the staff can discuss with anyone who is interested. But no, we fully expect the great majority of people are going to be taking other medications for other reasons. So that in and of itself would not be a reason to be determined ineligible. But there would be some scenarios where we may need to tweak the medication a little bit, but I'll leave those to those individual discussions we have with people who call us up.
Okay, great. Any more questions here? I got kicked out of the chat again, so.
Any other questions there, Leanna? Do you want to read them out if you see them at your end?
For sure, yeah, I can definitely read them out. So Sally Ann is asking, why psychiatry rather than immunology as the host/lead medical specialization?
Oh, it's a great question. And I think that the way medicine is now is that medicine is divided into different subspecialties because of organizational reasons. Mother Nature, when Mother Nature invents a disease, Mother Nature doesn't consider political or medical subspecialties. And most psychiatric illnesses involve disturbances in immunology. Most psychiatric illnesses involve disturbances in heart function, lung function, diabetes function, and so on. So because psychiatric illness involves your brain, and because your brain affects every single organ in your body, including the immune organ, because it really is an organ, then it made perfect sense that psychiatry, in fact, because many of our medicines not only affect the brain, but affect the immune system. And so that's in fact the reason why we've taken the leadership on this, because at the end of the day, people who have long COVID complain a lot about some of those symptoms of the brain: fatigue, tiredness, sleep disruption, depression, anxiety, brain fog. That's brain. So we thought that the world's brain experts should be leading this study. That's why we're leading it, and we do a lot of work with it with drugs and immunology.
Great, thank you so much. There is an earlier question from Holly. It's kind of multi-part. So she's asking, why Tritellix as opposed to other SSRIs? Is it a better anti-inflammatory? Is the dosage the same as prescribed under other circumstances? What is the impact of drug in boosting immune system on patients already taking a biologic to suppress the immune system?
Great questions. The reason why we chose the drug 40-oxetine is it's the only antidepressant that we have in psychiatry that the United States Food and Drug Administration identifies as helping cognitive functions independent of your mood. SSRIs like Prozac are not known to improve cognitive functions independent of people's mood. The other issue is, and Susie brought this important question up, and that was side effects. SSRIs have more side effects than a lot of people are willing to tolerate. And the drug that we chose has one of the best tolerability profiles. In other words, the side effect burden is pretty minimal, and people don't usually stop it because the side effects is very safe, very well tolerated. The other issue is that this antidepressant that we're using it off-label, not as in quotes an antidepressant. We're using it as a drug to treat long COVID. And the reason is not only because it helps cognition, but it also helps motivation. And a lot of people are telling us they have zilcho motivation thanks to post-COVID condition. But here's the other part, Leanne, and you know this well, is that of all the antidepressants we have, this is the one that kind of looks a lot like aspirin, in the sense that it affects a couple of immune systems in the body that aspirin affects. So it has immune effects, it has effects on cognition, it has effects on motivation and energy, and it doesn't have all the nuisance side effects. So for us, it was a no-brainer. This is the one we had to go with.
Great, thank you so much for the comprehensive response. So we have a few other questions. My colleague Felicia, and I will also try to get to some of them. So I'm just gonna scroll through a few. So the next one is, what if your doctor has already got you on an antidepressant to help with your lows and anxiety? Can you still participate?
100% yes is the answer. And in fact, depending on which antidepressant it is, and we won't go through all of the antidepressants right now, but some of the antidepressants that you are prescribed, we would just simply add this one to it. So you can take both of them in combination, not a problem. In some cases, what we'll do is we will ask people to stop the other antidepressant they're on right now to start on this one for the duration of the study. So the first point, and Susie and I discussed this, you can be taking medications for anything coming into the study, including biologics, not a problem. And those decisions are made on a case-by-case basis. If you're already prescribed psychiatric medication, more specifically an antidepressant, depends on which ones, we may just say, just keep taking it the whole time. We're just going to add this new one to your medications currently. But in other situations, depends what the antidepressant is, we might ask you just to take a hold on it for 8 weeks or so while you try this treatment as part of the study. And I can say it this way, if you're having symptoms of long COVID and you're on an antidepressant, by definition, the symptoms of long COVID are debilitating you. So therefore, whatever you're taking is not actually doing the trick anyways. So we're going to have to kind of relook at this. And I think, but these are decisions and discussions that will be had on a one-on-one basis. And we always tell people, let's have that discussion with your healthcare provider. So a couple of summary statements. You can take other medications while you're in the study. Secondly, you can take other psychiatric medications while you're in the study. Thirdly, you could take other antidepressants in combination with the antidepressant. Fourthly, some antidepressants, we may ask you to take a hold on it for 8 weeks, but that'll be a discussion on an individualized basis, and that'll be in discussion with your healthcare provider.
Yes, thank you so much. I guess we'll just go through a couple other questions. There's one by Nina, and Nina's asking, what do you mean by motivation? Because a lot of us seem to have the will to do things, but need to practice self-discipline to not overdo it, to stay within our energy levels.
Okay, so that's a great point. Motivation is a very complex experience. Let me just go through what I mean by that. So motivation could mean the inspiration to start a task. It could be the inspiration to complete a task. It could be the inspiration to complete a task to the best of your ability. They sound the same, but they're all quite different, actually. So to get out of bed in the morning is a very different inspiration than it is to maintain a high level of activity throughout the day, which is very different than trying to do your tasks at the highest level of quality you can do them. And I see people who have post-COVID and other problems with motivation who say to me, I just can't even get out of bed in the morning. That's obviously very severe. I will say, I can get out of bed in the morning, but after 2 or 3 hours, I'm spent. I'm usually good for 8 to 10 hours. I'm spent after 2 to 3 hours. That's a different situation. I mean, other people who say, I can get out of bed in the morning, I can do this, I can do that, but I'm only doing it kind of, frankly, mediocre. I'm not really doing a very good job. I don't have the ability, not that internal drive to do it at a quality that I once, in fact, thought I could. Or said differently, what some people are saying to me is they're saying, before I could put an 8-hour day in and I still got a lot of energy in the evening to watch Netflix, hang out with my kids, go work out, this type of thing, maybe read a book. Now I get home and I'm spent. I pass it on the couch. So motivation affects people in different ways. And what's really interesting, Leanne, about the treatment that we are studying is that it affects different aspects of motivation. In other words, it really affects the ability to get your day started. It affects the ability to maintain your activity level. It also, in fact, affects your motivation to do a high quality work. In other words, the type of positive experience you get doing those types of things. So motivation is really broken in different pieces, and the treatment we chose affects different parts of it because we know that long COVID affects different aspects of motivation.
I've got a question for you, Dr. McIntyre. You were talking about processing in executive cognitive function and processing speed. A lot of long haulers find that their processing speed is just slowed down to almost like a lapse in time where it just takes a lot of time for the thought to get out of the brain to do anything, especially driving, sitting at a light where it's almost like a delayed reaction for your brain to tell you what your eyes are seeing. Will this medication help with that?
100%. And you're absolutely right. In fact, what you just described, Susie, is one of the most distressing and debilitating aspects where, in terms of process, people just can't really process. And so that is an important human experience. It's obviously impossible to have any kind of quality of life with that type of problem. And it's just about impossible to function inside your home, outside your home with that type of problem. And over the years, I've taken an interest in that particular problem because that problem is not only seen in long COVID syndrome, that's seen in a lot of problems, a lot of medical problems. And look, no one needs to be a healthcare provider to say that doesn't sound too good. It's not good. It's very debilitating, lowers quality of life and function. So we have been looking at a number of different ways of trying to treat that in a way that's safe and easy to take medicine that can really turn that around. And again, I should always maybe make the comment that we can't guarantee anything in the study. We're doing the study because we really believe this is going to help people. And our experience with this medicine in other medical problems that we use it off-label or on-label has been it really helps those problems. That's why we think that if we apply it to long COVID, we have a high probability of success. So our fingers are crossed.
Okay, well, sounds like a great study to me. If people are interested, there's information in our group with the flyers of how to contact Dr. McIntyre and his staff. We will be posting those throughout the week. They are also posted in the I can't remember the name of the section, but we'll post those for everyone to see. As well, I just wanted to mention that there's also a paid incentive for this project, is there not?
Yeah, and I'll let Leanna, because Leanna's a bit closer to that than I am. There is, and it's less of a paid incentive, more than a compensation for your time for being part of the study. I happen to think that people's time should be respected. And out of respect for that time, there is some compensation, financial compensation to participate in the study out of respect for your time. Leanna, and so if you're interested, what I think would be better is just people reach out, talk to the team. They'll be happy to speak to you about that.
Yes, that's correct. For anyone who has any questions about the study, as well as any questions that unfortunately we were unable to get to in the chat, please feel free to email us at longcovid@bcdfoundation.ca or give us a call at 647-450-8045, as you see on the slide here, and we're happy to answer any questions you may have.
That's great. Thanks, Leanna.
Thanks,
So
Leanna.
thank you, Dr. McIntyre, for taking the time to explain the study and long COVID on the brain, and we look forward to participating.
Great stuff, Susie. We'll keep the communication lines open, and great having this conversation. And look, it's about having hopeful research, and I hope this is really going to help a lot of people. Don't hesitate. Reach out to the team, Leanna and the whole team. They'll be more than happy to speak with you, and we'll keep in touch.
Thank you so much.
Take care, everybody. Bye-bye.
Bye for now.
Bye-bye.